Good morning, everyone. Welcome back to our weekly CMR conference series. We're pleased to be joined by Dr. John Grizzard, who many of you know is associate professor here at VCU and is the co-director of cardiothoracic imaging within radiology here, and a wonderful resource for many of us clinically and academically. And so we're very lucky to have him present on this topic. So Dr. Pauley went through some of the nuts and bolts of how images are generated in the MR environment. Now Dr. Grizzard is going to go through what this looks like in practice as we choose different sequences on the scanner and what the implications of those choices are. And just a reminder to everyone, these sessions are CME and MOC accredited, so don't forget to text the link or text in the code on the screen to the number provided. And for the trainees, the residents and fellows who are attending, we might not go through any extensive cases today, but in future sessions, if we go through cases, you can log those as part of your case training, and we'll try to keep a tab of how many cases we cover in each session for your training purposes. And with that, I'll turn it over to Dr. Grizzard. Thank you.
Okay, great. Thanks, Corey. Okay, so yeah, this is like a study of the nuts and bolts of cardiac MRI scanning and stuff like that. And I think, for those of us who were dinosaurs back in the day and remember when MR first started, the idea that you could image a moving heart seems like science fiction, because if you do a head CT, if the patient moves a little bit, the images are pretty much ruined or at least compromised, whereas the heart's moving all the time. So it's really a series of pretty elegant engineering and programming feats that enable us to do what we do with cardiac MRI. The early cine images to look at the cardiac motion and overall structure and function were largely gradient echo sequences. That's a certain type of scan sequence. But what we use now results in a very nice bright blood image with a very dark myocardium, and those are called steady state free precession, and those are the cine images. So there's been gradual improvements in the techniques, and like for MR angiography now, this is a volume rendered image, but of an MRA, you can really get pretty good coverage. I mean, that's covering from the thoracic inlet all the way to the bifurcation of the aorta and so forth. So, the field of view has gotten progressively increased as well. More importantly, I think the development of the inversion recovery delayed enhancement sequence, or late gadolinium enhancement is what some people call it, gives you a very precise depiction and localization of myocardial scar or cell death, either from infarction, like in this case, or in other cardiomyopathies, as we'll discuss. So I think it's useful when you're thinking about this is to go back to the beginning and pretend that you were inventing MR. Like, so what are we trying to do exactly with this? What does the heart do that we want to be able to understand or visualize? So in the normal situation, the heart is really a pump, that elevates the pressure. The ventricles raise the pressure up to either pulmonary arterial levels or systemic levels, and then drive that through the whole circuit through a series of progressively lower pressure systems. In a disease state, that muscle may have a genetic muscle abnormality that leads to impaired function, maybe other things that injure the muscle. Valves are supposed to be present that ensure the flow occurs in just one direction, as a valve will do, but they can leak or become narrowed. And so they can either allow retrograde flow where you don't want it, or they can be narrowed and obstruct the flow. The heart has a blood supply that enables it to function, the coronary arteries, and if those get blocked up, you can suffer myocardial injury or cell death, as we were showing you. And the heart can be damaged if the blood supply is diminished, even without infarction necessarily, but with infarction, you often lead to impaired function. So just to give examples, for instance, the top image here is a normal short axis cine image. The bottom image, you can clearly see that myocardium is way too thick. So we like to be able to depict the structure and the function of the myocardium. Here you see in the top a pretty normal looking aortic valve without any regurgitance. At the bottom, you see somebody with dilated aortic root and pretty severe aortic regurgitation, noted there by that dark jet of flow. Let me just point out that it may not be apparent from this that the reason that we have signal in the blood pool here in the left ventricular cavity and in the aorta in the top image is that we have a sort of a coherent phase, a coherent information, if you will. There's a steady state of magnetization that's been achieved, and that results in very high signal on these steady state free precession sequences. However, what you're seeing here is what we call spin dephasing. It means that we've lost phase coherence. The protons that are composed in the blood are knocked off their axis and are spinning chaotically, and therefore you don't have uniform signal intensity. And in fact, it appears as a flowed jet or a dark area. This is important because later we'll be trying to quantitate retrograde flow, and we'll be using a sequence of phase contrast velocity encoded study. And interestingly, the information that you want is encoded in the phase pixels. Well, if you think about it, the phase pixels here are all messed up. You have dephased these pixels. So you're going to have a problem when you try and use the retrograde through plane flow sequence to try and understand how much regurgitance you have. You can see why the spin information is encoded in the phase pixels and they are dephased. So you're going to lose those pixels. Here's a normal through plane flow study in the top image with a tri-leaflet, Mercedes-Benz looking aortic valve. And then at the bottom, you have a bicuspid valve. And that's, pretty easy to see. In this case, the bicuspid valve functions pretty normally. There's not a lot of retrograde flow. Another thing we'd like to be able to do is evaluate for coronary blockages, areas of impaired perfusion. At the top, you see a normal perfusion image. I should find one that has a better dark rim artifact, which provides the greatest source of confusion in interpreting perfusion imaging. At the bottom, though, you have a pretty clearly abnormal perfusion sequence. And as opposed to the delayed enhancement sequence, on these images, it's the dark area that's abnormal. So you see that anterior septal wall is dark. It's not enhancing to the extent because it's not getting a symmetric amount of blood flow as the rest of the myocardium. This is the late gadolinium sequence that I think is, one of the tremendous developments that's really moved the field along. And in this circumstance at the top, the normal late gadolinium enhanced image, the myocardium is maybe not jet black, but it's pretty dark gray. And in the bottom image, the white area is an inferior wall infarction. And notice how, as opposed to a lot of imaging techniques, you can actually grade the transmural extent of the infarction. You can say, okay, here it's greater than 75%. Here it's maybe 25 to 50%. Maybe here again, it's focally thicker. So that's important, as we'll talk about. So what's a standard scan? Well, we often start with still frame or snapshot, single shot images, we call it, with either dark blood or bright blood. We always do a series of cine images through the heart to quantify cardiac function. We'll often do flow sensitive sequences, particularly in instances of suspected congenital heart disease or leaky valves. Those will become important. Perfusion sequences in the cases of stress testing, or sometimes for other things like looking at masses. And then viability or late gadolinium enhancement sequences are useful for a variety of reasons, as we'll talk about. So one of those still frame images I was discussing. So these are used to get an overall overview of the cardiac and mediastinal anatomy. So we term these morphologic images, and often we'll get them in the standard radiographic, at least standard imaging planes, which are axial, sagittal, and coronal. The localizers are certainly done in all three planes, but when we're doing these single shots, we'll often do them, at least in the axial plane. And again, for suspected congenitals, we'll often add a sagittal and coronal. They're ECG triggered or gated scans in that sense. The dark blood sequence is, in the Siemens world, is termed a HASTE image, half acquisition, single shot turbo spin echo, and it's ECG triggered. Just to be clear, for GE, it's called double inversion recovery, and the Phillips acronym I'm not sure about, to be honest with you. I think it's called balanced fast. No, it's not called balanced fast field echo. That's the SSFP. At any rate, all vendors have these dark blood sequences, and they can be done with fat saturation or without. What does a double inversion mean? Well, what you're doing really is you first give a non-selective inversion pulse. So all the spins that are normally aligned with the magnetic field, there's a slight predominance of, so that you get a net vector that aligns with the main magnetic field. And you flip those upside down by giving a non-selective inversion pulse. So the entire patient, if you will, has an inversion pulse. Then you revert the slice area that you want, the single area that you want to have signal, you give a second inversion pulse that basically restores the magnetization back to baseline, really. And then you can run your sequence. But first, you put in a little bit of a delay. What happens in that delay is the blood in the slice that's had magnetization restored can move out of the slice, and therefore, and blood that moves into the slice will be inverted and will gradually reach what we term as the null point. The inverted blood moving in is going to lose signal as it reaches the null point. That is, when you're inverted, you're at, let's say, -10. You go from +10 to -10. Well, you gradually, as time goes by, go to -5, -4, -3, -2, 0, and then +1, +2, back up to +10. And the rate at which you do that is termed T1. That is what T1 refers to, and hopefully Dr. Hundley covered all this. But basically, when you're at 0, you have no signal, and at that point, you want to image that, and therefore you will have dark blood. So you run your turbo spin echo sequence run at the time that the inverted blood has reached the 0 crossing point and has no signal. And that results in the dark blood appearance. Here's a representative stack of images. Here's a haste image. Those very astute or oriented towards congenital heart disease will notice that this is in a transposition with a very thick-walled systemic right ventricle. We'll let it play again just so you can appreciate how you can see the walls very nicely, how thick the myocardium is, and you see the blood pool is dark black, and et cetera. Notice the aorta is anterior and to the right, which it should not happen that it's anterior to the, here's a normal patient without fat sat, and then with fat saturation. So these can be done with or without fat sat, depending on the indication. Maybe you're studying a mass and you suspect that it's a lipomatous hypertrophy or a lipoma, you can do fat saturation. So these are great for rapid morphologic imaging. Each image takes less than a second. We don't have them even breath hold for these. You can do them in any plane. And as I've mentioned, you don't need to do it with breath holding. So the bright blood imaging, how do we do that? Well, we use the steady state free precession sequence that I previously mentioned. Often we're using it in a cine mode where we're rapidly acquiring a series of images, but all in one location. What I'm going to discuss now is basically we're getting a single image at multiple locations. So it's a little bit of the almost exact opposite. Here again are some acronyms. Siemens called it TrueFISP. Really, balanced steady state free precession is the generic name. GE is called Fiesta. Philips is balanced fast field echo. But they're all the same sequence, basically. They're single shot in this manner. They're single shot images. They're not segmented or built up over multiple cycles, as again, I know Dr. Hundley discussed. They're very rapidly acquired. Again, they don't require breath holding because they're so fast, and they give you bright blood images. With balanced steady state free precession, the contrast is dependent on the T2 to T1 ratio of the tissue. So weirdly, both fat and fluid tend to be bright. And it kind of, if you look at them, you're going to think the images are T2 weighted, and they mostly are. I'll just say it's more of a hybrid, though, than a pure T2. Let me just mention we get these as we did the haste images with a matrix of 256 by 200, and typical slice thickness is 5 to 6 millimeters. We often do these with a small gap in between them. Just, we're just screening through the chest, but you can do them without a gap. And you can get the whole stack of these in less than a minute, really. Here you see a case where we're looking at pulmonary veins. So it's nice looking at intraluminal abnormalities, dissections, cases. You can put somebody on the table and rule in or rule out a dissection without even starting an IV, just by running these haste and FISP images, and be done in about 2-3 minutes. So, we don't often get asked to do that, but it's a very nice test for that if you decide you want to try it. Here's what it looks like when you have a dissection. Notice the dissection flap in the descending aorta here, evident on both the dark blood and the bright blood imaging. And in fact, there's a hematoma in the anterior mediastinum, kind of goes by pretty quickly. We'll let it play one more time. But notice the flap is very easily depicted without contrast. And so, renal failure or whatever, doesn't matter. And then in the ascending aorta, there's wall thickening and a hematoma there. And again, here's just some still frames from imaging of the aorta in a patient with a type A dissection, and they can be obtained very rapidly. Other standard sequences like T1 and T2 fast spin echo images can be done. I don't do a lot of these. I think they can be useful for masses or to evaluate, the composition of something you're suspecting might be a cyst or something like that. They allow a little better tissue characterization because as opposed to the single shot sequences, which are kind of hybrids, in the sense that they're not true T2 images or true T1 images, you can make these absolutely T1 or T2 imaging, and you can perform them with or without fat saturation. So here's a T2 image without fat saturation. Notice that the subcutaneous fat's pretty bright. The myocardium is medium to dark gray, and the pericardial thickening is well displayed in between the epicardial fat and the mediastinal fat. So standard sequences are, they're pretty helpful in masses cases. I would just point out that, like, if you did a perfusion sequence, that's going to be a T1 weighted image as well. You can do a standard, example like this, but you actually already can know what the T1 characteristics are from that. T2 imaging is here. Notice that this myxoma is quite bright because it's a gelatinous lesion that has a high fluid content. And so they're very useful. T2 images are most useful for showing fluid content and edema. T1 images, are more useful for showing basic anatomy, T1 properties, but mostly are useful in cases where you're trying to evaluate for contrast passage. Here's a cyst. Notice how it's kind of iso intense, or whatever, on the T1 image on the left. On the T2 image on the right, it's quite a bright cyst, pretty obviously fluid. If you're a little bit of a quandary, like what kind of sequence is this, or what am I looking at in terms of its weighting, remember the spinal fluid is always a good kind of surrogate for fluid. So notice in this case, the spinal fluid and the cyst are both bright. You pretty much should know right off the bat, then this is a T2 weighted sequence. Okay, so something that doesn't get mentioned enough when people are talking about sequences, I don't think, is the IPAT, or the image acceleration techniques that we use, where basically you're taking multiple different coil profiles and using them to reconstruct data lines that you're limiting, you're not actually acquiring. So parallel imaging can reduce imaging time directly proportional to the parallel imaging factor. The image resolution, as we know, when we're scanning anybody, the image resolution, the phase encoding direction, is determined by how many phase encoding steps you have. So the frequency encoding doesn't matter. Remember, frequency is free, meaning there's no time penalty for that necessarily. But the acquisition time is dependent upon the phase encoding steps that you require, how many of those you get, and what your matrix size and resolution are. So for 256 by 200 matrix, what we're referring to, the 256 refers to the frequency matrix portion of the matrix, and 200 is the phase encoding. So you have to fill 200 phase encoding steps. Each has an imaging time of temporal, TR, which is repetition time, and they have to be acquired, right? But what you're able to do if you're using parallel imaging, and I think everybody uses this now, particularly in cardiac MRIs, that you're using each coil's different sensitivity profile, because each coil gets a slightly different signal from a different region over field of view. And you have to have at least two of those coils placed in the phase encode direction. And then what you're doing is basically undercounting the phase encoding lines and interpolating them. What's the trade-off? I mean, why not do it every time for everything? Why not do it with a parallel factor of 5 or something? So parallel imaging reduces the phase encoding imaging steps by the acceleration factor. Most times we're doing it with a factor of 2. Sometimes we go as high as 3 at 3T, because you'll see why you don't want to go crazy with this. Phase encoding acquisitions are roughly a little bit more than half of the usual, but if you do a phase encoding IPAT factor of 2, you get a twofold, not quite twofold time reduction, because you're only getting half as many phase encoding steps as usual, right? Every other phase encoded line is obtained and every other line is missing, but they're filled in using the different sensitivity profiles provided by the multiple coils to synthesize the missing phase encoded lines. So The downside is there's always a downside for something like that. For a twofold acceleration, there's a 1 over the square root of 2 reduction in signal to noise. So if you do the math on that, 1 over the square root of 2 ends up being about 70%. So I'm sorry, 30%. That's reduction in signal to noise. You get, in other words, you have about a 70% residual signal. So for something like steady state free precession cine images, where you have a lot of signal, it's not that much of a penalty, and most people use an IPAT factor, parallel imaging factor of 2, pretty much uniformly, right? Same thing with MR angiography, which is also a very signal-rich thing, and late gadolinium enhancement. Signal to noise is therefore about 70% of what it would be. So that's not much of a penalty, right? Okay, moving to cine sequences, SSFP is really replaced, in most instances, flash or gradient echo sequences. There are exceptions to that, as we're going to talk about. Remember that the contrast on steady-state free precession images is dependent on the physical characteristics of tissues. It's not the inflow of moving blood, whereas with the old gradient echo sequences, you have to have some movement of the blood pool, or it will be static and lose signal. So even slow flow can be depicted, and there's a better definition of the blood pool endocardium interface with most cine images. Here's a standard short axis image. Notice how well you see the tricuspid valve leaflets, even though they're very delicate and thin. Here's a nice 3-chamber view, easily depicted 4-chamber view, etc. Notice on the 4-chamber view, we'll talk a little bit about in subsequent lectures on pericardial disease, you know, how I'll say, oh, notice how on a 4-chamber view, the free wall of the right ventricle slides by the pericardium. That's a really nice example of it there. You can see how those are not stuck together. Okay, so you can really see motion quite well depicted. You can also measure chamber size and wall thickness, and they allow you to assess valvular morphology and function. You can get them in any imaging plane. Here's our typical acquisition parameters. We do them with a matrix of 256 by 192 or 256 by 200. That's your, base resolution. Your temporal resolution is dependent on how many phases you require per TR. So you want to try and keep it under 50 milliseconds. It's actually better if you can keep it at 45 or less. And you can reconstruct it with view sharing up to 25 phases. Slice thickness, we typically get 6 millimeters with a 4 millimeter gap, but a lot of people will get contiguous 8 millimeters with 2 millimeter gaps, or even 8s that are contiguous. It doesn't, I don't think anybody's ever shown that makes a huge difference. I would point out that due to some slice blurring and volume averaging effect, that when we get these 6 millimeter slices, it's probably actually getting closer to 8. And when you get 8, you're actually probably getting closer to a 10. So we go with the thinner number. Standard views include the incomplete stack of short axis images that enable us to calculate function and so forth. The standard views also include 2, 3, and 4 chamber views. And this is probably incapable of being read on a screen as it is. But I put it in here because it might be possible, if you can download this talk or review it or whatever, to be able to see. And then I actually did some where it's a little bit more readily readable. The point I want to make here is that I put in here the imaging parameters, the field of view, the matrix slides, and slice thickness, and how exactly we acquire these. This is the late gadolinium segmented acquisition. Our matrix size tends to be 256. I would say we'd probably go up to 180 or 200 on that. Notice that even in the real times, we'll try and take our matrix up to 192. And for our single shots, we'll do those at 192 or 208 by 128 pixels. And you'll have a slight thickness of 8 millimeters for those single shots, and why they're useful. So this is in your, if you review this or whatever, and or if somebody wants, I can give you this as a handout or something. Optional sequences, we talk about bright and dark blood imaging with morphologic images. Here's how we do the T2 images, flow sensitive sequences, etc. But notice that our matrix is pretty much always at like 200 or better to get pretty good high resolution images. So what is a standard scan? Well, we start out getting a planning image. We get a series of low resolution localizers, and we draw this line that bisects the axial image and gives you a 2-chamber view. It's a low resolution Scout 2-chamber view. You take that and you bisect it, as you see there, just a little bit lower than halfway from top to bottom, maybe just a little bit less than halfway up, and you get the 4-chamber planning image. Then you bread slice that and you get the short axis. So you want to go perpendicular. Each time, for the technologists, I'll just mention this, each time that you're getting these acquisitions, you should right click, at least on the Siemens scanner, you right click and hit perpendicular so that you're actually getting orthogonal views. If you don't hit that, you can get a little bit off axis because you may not be parallel to the in perpendicular to the entire plane that you were in. So doing it that way, you get these short axis views. We then get a stack of these short axis views from base to apex. As you see, we typically go from the apex to 1 or 2 slices above the mitral valve plane. In congenital cases, we'll go all the way through the right atrium in a series of images so that we can look for septal defects and so forth. There's a 2-chamber view. You see the 3-chamber view, 4-chamber. We typically get these on all our patients. It gives you the best overall review of their function. Let me just mention that the people who draw the circles know this, that we can do functional analysis on these cine images. What we do is we take the still frames that are showing from the image on the far left, A, to end systole, which is H, and that allows you to trace those endocardial contours and therefore calculate the volumes and stroke volumes and ejection fraction, rather. So there you see diastole and a series of images with tracings and their systole. And so what you're really looking at is how much of the blood that was present at the beginning of a contraction is present at the end of a contraction. That's going to tell you what was ejected, right? The ejection fraction. The important thing to know about MRI as opposed to echocardiography is that you can find very small differences because it's very reproducible. That is, if I do a series of tracings of circles like that, and then Corey Trankel does it later, and if we differ, then we'll know that Corey is wrong. But leaving that aside, and seriously, you'll only have at most 2 or 3% difference between different observers. I think the average in studies has been about 4%. And the main area of discrepancy when you're doing those functional tracings is how you handle the basal-most slice. I think newer software allows you to know where that basal slice is relative to the mitral valve and to know whether or not you're in the left atrium, and you don't have to make adjustments based on what percentage of the wall you see on that. So I think we're probably going to be even better on this, but it's very reproducible. You can pick up a 3% difference in ejection fraction in a series of patients with 90% power and only have to use 11 patients, whereas for echo, you would have to do about 90 in this study that he reviewed. So a lot of new treatment trials looking at conservation, myocardial conservation from myocardial infarction, and they'll intervene with a new agent or treatment. They're going to do MR for follow-up because it's the most accurate means to serially follow LVEF and LV mass and volumes. Okay. So there we're seeing that their breath hold exam, we're using gating. So what can go wrong? You notice these images are not quite as pristine as some of those other ones, but if you have them do better breath holding, you can get rid of the motion artifact. How would you know that that was what the problem was and not arrhythmia? Well, look at the diaphragm. In the image on the left, I would argue you can kind of see stuff's moving around. This is not staying stable. Whereas here, everything is pretty much, this diaphragm is not moving. Here's another one. Is the diaphragm moving? Really not. That's pretty still, right? So what's going on in those sequences is that you're having arrhythmia. So just to point out, and again, Dr. Hunley covered a lot of this, but I'll just briefly mention that our standard sequence is retrospectively gated. That is, data is acquired throughout the cycle and is kind of time-stamped to allow it to be put into a proper segment of the cycle. So that you might get your first 15 lines of K-space will be in here. And then you get the first 15 lines of K-space from this beat. And then you get the first 15 lines of K-space from this beat until you get 200 lines of K-space, which will take, 14 beats or whatever. Although with iPad, it'll maybe be 7 or 8 beats. Okay. And then the second 15, so lines 16 through 30, then 16 through 30 of this beat, and then 16 to 30. But the point is you're getting these lines and you're presuming that the 16 through 30 of this beat is going to be the exact same location or whatever as the slice before. Now imagine all of a sudden that I'm trying to acquire these images and I throw a PVC in right here. Well, lines, whatever that would be, lines 50 through 65 are going to be screwed up. So you're going to have motion artifact, right? The segmented acquisitions, what we mean by that is the data from several cycles are combined to yield an image. You're acquiring part of each image from multiple beats. But you have to have a regular rate and rhythm for that to work, right? And when you have arrhythmia, the retrospectively gated sequences are going to become blurred. Like here, we kept losing the ECG signal because of that large pericardial effusion, and you have kind of a very blurry picture that results, right? So, that happens all the time in the settings of arrhythmia. But what you can do then is use a prospectively triggered sequence. Well, how does that work? What you do is you start with the R wave and you acquire for some variable length of time, and then you cut off the acquisition. So let's say that you're having PVCs that are occurring, at your basic cycle is 60 beats per minute, but every now and then you throw a beat that's coming in at 500 milliseconds, seemingly at 120 beats per minute. What you can do is you can actually set your prospective sequence to start at the R wave and then go for 490 milliseconds, and you'll cut off all those arrhythmic beats, right? So the only problem with doing prospectively triggered sequences, you're going to cut off a portion of diastole. So here you see on the left side of the images, arrhythmia-induced problems. Here you see prospectively triggered. Notice it's a little herky-jerky compared to the steady state retrospective sequences, right? These are a little bit herky-jerky, and that's because you're missing that last little bit of diastole and making the entire cycle complete. So you're starting you're starting off with a little bit of a gap, and that results in this herky-jerky sort of movement. You can just look at these after a while and say, you had to switch to prospective triggering, didn't you? Okay, well, what happens when you just can't even get a signal? As I mentioned, this patient with the large pericardial effusion, the image on the right, we were just trying to guess. Prospective triggering didn't even work, right? Because you have to have a signal to be able to do it. But you can do real times. So real times, you don't even have to have an ECG going. Let me just mention in this image on the right, this is what an iPad artifact looks like on a cine image. It's not usually when we get RAP images, they're on the edge of the image. The patient's nose will appear at the back of the head on a sagittal view or something like that. But iPad images, iPad artifact will tend to be right in the center of the image here. And that was fixed here by enlarging your field of view or adding phase encoding, phase oversampling, and we got rid of it. Yeah, I just mentioned that. Okay. Real-time imaging can be performed with or without ECG triggering. It's relatively impervious to any kind of arrhythmia, but the images are of lower resolution. But they are useful for doing dynamic imaging. Like here we have this patient and we did real-time imaging. We had this big pericardial effusion. We were trying to decide, is this hemodynamically significant? Well, look how that septum gets flattened out when you take a deep breath in. What that's telling you is that the total volume within the pericardium is a fixed quantity. We've reached the elastic limit of that pericardium. And when we increase when we increase the right ventricular volume by inducing negative intrathoracic pressure with a deep breath, we pull blood in from the outside, we enlarge the right ventricle. Well, the total volume inside that pericardium can't change. So if the right ventricle gets bigger, the left ventricle is going to get smaller, right? And so you see that septal shift, and similar things will be true in cases of constriction. Special adaptations of the cine SSFP sequences include doing small field of views where you deliberately, shrink the field of view way down and put phase oversampling on it so you don't wrap, and you can get these high resolution images of very small structures like this. Flow studies. We do flow studies quite often just to, measure the flow through the aorta. It's helpful when you're trying to quantify mitral regurgitation. Paradoxically, you can get a better idea of what regurgitant fraction is by looking at your stroke volume of your LV from the cine images and then measuring the forward flow through the aorta. The difference is going to be what went backwards into the mitral valve or through the mitral valve. So, but you can do these flow sequences, and they're obtained by applying two opposing gradients that are separated briefly in time. They're opposite in direction. So what ends up happening is the stationary tissues don't acquire a net phase change, but flowing structures or protons moving through the slice will see different parts of that pulse. It may see one pulse entirely, but miss the second pulse entirely, or just get a portion of that. And as a result, you can encode both the direction and velocity of flow by using the phase change. This is kind of an interesting eye test for anybody who's looking at that. It kind of looks like a bicuspid valve, but actually it's a unicuspid valve, and I just throw that in for fun. You can tell that because it doesn't go all the way from wall to wall. It just goes about halfway. Net phase change in the moving spins will be dependent on their velocity and the direction of the flow encoding gradient. So we're typically using these to grade flow across stenotic or leaking valves, or in the case of a suspected septal defect or something, we'll measure flow through the aorta and the pulmonary artery and so forth. Stenosis quantification is done using the Bernoulli equation, which is a sort of a shorthand way of figuring out the gradient from a velocity. You take the velocity in meters per second, which unfortunately the scanner gives the velocity in centimeters per second, so you just have to convert that. But like, in other words, if they're doing their velocity encoded flow studies at 300, they're saying 300 centimeters. So that's 3 meters per second. So you take the gradient and let's say you get a gradient, a velocity of 300 cms, per second. That's going to be 3 in meters per squared. You'll square that, so that's 9, and then multiply times 4. So your gradient's going to be 36 millimeters of mercury, right? Here's a case where you have a very stenotic aortic valve with some leakage as well. Here's another one you can kind of see. Even though we have wrap, you can still work around that pretty much. And you can take one mistake I see people make with velocity encoded flow studies is they'll use a whole like 380 field of view. You really shouldn't. You should cone it down so you get more pixels going through the area of suspected stenosis, and you get more counts that way. And if you have wrap along the periphery of the image, that's, you don't care about the wrap. But in this instance, it wrapped right into the pixel, so that's not ideal. You don't want to get into the area you're measuring. But anything short of that, who cares about the wrap? So you can do that. You can freely select the gradients. I think our maximum maybe 600 centimeters a second. If you choose too low a velocity, you'll get aliasing. People who do echo are familiar with the concept of aliasing, where the velocity information exceeds the upper limits of measurement and will appear to wrap around in reverse polarity, right? So what you'll see is apparent flow reversal that's discordant with the cardiac phase. In other words, you'll have a systolic image, and all of a sudden, right in the middle of systole, you'll have apparent diastole. That doesn't make any sense. So that's aliasing. You can note that, and you'll fix it just by repeating the sequence with a higher velocity. So here's a case where we did it at 150, and the patient clearly is aliasing there. Notice you're starting out systole, forward flow is black, and then all of a sudden you have apparent regurgin of flow in the middle of systole. That just doesn't make any sense. So that's aliasing, right? And then if you go to a bank of 300, you get rid of it. Okay, so that's pretty easy to figure out. You can use that to measure flow. You can quantitate shunts or regurgitant volumes. Remember that flow is just the velocities over the area, and we use it all the time for, like in this case, you have a ostium secundum ASD. You see transeptal flow going there. You'll measure the flow across the pulmonic valve or the pulmonary artery. Similarly, you'll do it across the aorta or proximal aorta, and you'll then compare those, and you'll get what's termed a QP to QS. And in this instance, it's 148/70 roughly. So you have a more than 2-to-1 shunt. Okay, moving on to perfusion sequences. MR perfusion has actually gotten increasingly recognized as a valuable alternative to a lot of other non-invasive imaging techniques, because it correlates really well with fractional flow reserve, which is becoming kind of the invasive fractional flow reserve is kind of becoming the gold standard for whether or not you'll gain benefit from revascularization of an apparent stenosis, right? So what would you like in an ideal technique, to assess cardiac perfusion deficit. You'd like for it to be non-invasive, preferably no radiation. You'd like for it to not kill the kidneys. You'd like for it to be quick, 45 minutes or less to perform, and pretty quick to read. And you'd like for it to provide good information about viability, all of which MR does. So how is its accuracy? It's probably in the 85 to 90% sensitivity and specificity. And I think to some extent, that may improve at 3T. I think 3T is going to be better data about that, although that literature is not developed yet. It's actually better in head-to-head trials than SPECT imaging for the detection of significant CAD. But you have to have good temporal and spatial resolution, and because what you're trying to do is demonstrate the passage of contrast through the myocardium in a reliable manner that reasonably reflects the myocardial blood flow. And you want to be able to cover the whole LV so that you don't miss anything, right? So you need at least 3 and preferably 4 slices. And we typically do these with stress and rest images. We do these using gadolinium chelates to provide contrast, which diffuse rapidly from the intravascular space into the interstitium and then remain to some extent in the extracellular space. We'll typically get 3 to 4 short axis images. Here's what they look like. Notice first you have RV filling, then the LV, and then the myocardium. I'll just let that play for a minute. And they go by pretty quick, but the nice thing is you can slow these down and play them frame by frame. We'll typically use regadenoson, or more often at our place, adenosine is used to reduce pharmacologic stress. As a standard protocol is to give 140 micrograms per kilogram per minute for 2 to 3 minutes. You don't really need to go much beyond 2.5 to 3 minutes. You've got maximum physiologic effect. With adenosine, the offset is quite rapid as well, with essentially clears within a minute. And its use is based on the same principle that we are familiar with from nuclear medicine, where you're looking for diminished flow reserve in a region of myocardium supplied by a stenotic vessel, right? So in this instance, at rest, you have maximum downstream, reflex vasodilatation in a downstream from an area of stenosis. But when you do vasodilator stress and dilate up the normal vessel and increase its flow, this one cannot increase its flow, and it's going to appear as a relative flow deficit, because it cannot augment flow. And typically what you'll see is that ischemic myocardium will be both darker and slower to enhance, right? Where relative to normal myocardium. These are signal intensity curves. So here's a still frame from a case where you have a septal perforated that's highly stenotic, and you see a very nicely depicted defect there. That would be tough actually to distinguish from a dark rim artifact, except those are usually larger. So here's a case that was I got from Duke, actually, of a young, not young, 57-year-old guy presenting with chest pain. His stress echo, interestingly, was negative. They did a perfusion scan, though. And I'm going to let that play a little bit because it goes by fairly fast. Look at the middle frame. And I think you can see an inferior wall deficit or dark area. I'll freeze that for just a second down here. It's kind of hard to see elsewhere, but this persists over multiple beats and was felt to be a real finding. He did not have infarction, which is important to compare the delayed enhancement images with that, so you know whether you're dealing with an infarction or an area of ischemia. And indeed, he had no infarct, but when they took him to cath, you can see the folks who do a lot of cath will recognize an RCA occlusion right there with a big collateral. Here's another case, lateral wall ischemia in this instance, with no infarction. There's a stress image on the left, rest image on the right, and you can kind of see a very well depicted area of ischemia. People who do a lot of perfusion imaging will tell you that the positive ones are really not that hard. It's the negative ones that we're not sure about a lot of times. In other words, when they're really positive like this one, you don't really struggle so much. Other uses for perfusion scans, they're very helpful, I find, in mass cases. Like in this guy has big hypervascular mets from renal cell carcinoma. Look at the enhancement of the met in the anterior wall, the mets in the inferior wall, even the met in the lung lights up, right? So they're, and it doesn't even take that much contrast. This, I think, was 5 cc's or something. It's crazy. Okay, lastly, I think it's important to realize that to some extent the idea of developing the delayed enhancement sequences so that you could, depict small areas of infarction. And as Bob Judd said, he figured they didn't know exactly what it would be useful for, but they figured it got to be useful for something, right? So myocardial dysfunction can be due to infarcts with scarring, but they can also be due to like hibernation, for instance, where you get a state of myocardial downregulation that occurs in response to chronic ischemia, and it can be reversed, right? So here's what normal function looks like, right? Normal two-chamber and normal short axis. Here's one on the image on the right. Clearly, that anterior wall is not healthy. But is it reversible or is it irreversibly injured? So that goes to what do we mean by viability? How do you define it? Echo a lot of times talks about the thickness of the myocardium is less than 5 or less, maybe it's dead. Recovery wall motion on a dobutamine stress echo or dobutamine stress CMR might be deemed evidence of viability if it can recover. But really, it should be whether or not the myocytes are alive, right? And cardiac MRI is the most accurate means of detecting prior infarction, and the absence of abnormal enhancement on delayed enhancement imaging is strong evidence that you have residual viability. So I was saying, some of the impetus for this was, wouldn't it be nice if you could see MIs? Well, it'd be even better if you could see them with high spatial resolutions, and better still if their detection makes a difference, right? So, for instance, here's a SPECT case, and that's clearly abnormal. There's a defect in that inferior wall, right? And, SPECT, if you have a nearly transmural infarct, works fine. The correlation here is a SPECT with a dog model and MR in the middle image of the bottom row, and then the histologic specimen. But let's say you have smaller infarctions. How well does it work? And we'll look at that. So what are these late gadolinium enhancement images? They're segmented, meaning acquired over multiple beats, inversion recovery images. We're using the inversion recovery to knock out the signal from the normal myocardium, because normal myocardium takes up contrast as well. The right inversion time to use varies as a function of how long after the contrast you're imaging, how fast they clear the contrast, and how much contrast you gave. So if you use less contrast, you'll have to image earlier. You'll have to use a longer inversion time. If you're late, you're maybe 15 minutes out, you use a higher inversion time, etc. So they both scar and normal myocardium take up contrast. How do you get rid of the, it's like the old line about the polar bear and the snowstorm. Well, the goal here is to get rid of the snowstorm. You take advantage of the differential contrast kinetics, and you can knock out signal from the myocardium that's present here and absent here. And now you can see the small subendocardial scarring. So how does that work? I don't want to get in too much into physics, but basically, as I said before, when we were talking about the haste imaging, you hit things with an inversion pulse, and then you let go of it, basically. And the things that have short T1s pop up most quickly. So contrast-enhanced MI will pop up very rapidly. Normal myocardium, a little less rapidly. Thrombus, much less rapidly, right? And when they're at this point right here, they're at the zero crossing line, and they have no signal. So myocardium will actually go to zero just earlier, right? And it'll recover by the time you image a null normal myocardium. So what you're doing is you're picking this time point to knock out signal from normal myocardium, and infarct will be bright. Paradoxically, in a standard, inversion recovery image, so will thrombus, but we'll talk about how we fix that. So here's an inversion time scout series where we're acquiring different images at different inversion times. So here it is at 250. Notice early on, if you image too early, you have a lot of signal in the myocardium because it's so far below the zero crossing. And even here, you might think, well, that's diffuse enhancement of hypertrophic cardiomyopathy, or something like that. So it's better to be too late, right? If you're late, you can still see the infarct, but you don't get confused by normal myocardium here. These are all too late, but I would argue they're better than being too early like this. So for technologists, if you're going to make a mistake, make it on the side of being too late. And although you might say, oh, that's perfect. Look how jet black that is. Yes. But if you try to get this just jet black like this, as time goes on and they lose their contrast, this will actually become too early. 250 milliseconds will be too early. My advice is don't try and be right here where it's jet black. This is the one you want, kind of dark gray. Because then even if they lose the contrast a little bit as you scan over the next couple of minutes, they won't get to this point where they're too early, where you're too early, okay? Remember, the contrast is going to wash out, and your apparent correct inversion time is going to be longer. But you want to use one that's a little bit longer to begin with than what you would deem perfect, okay? Okay, so I think the point is this is actually when we've knocked that signal from the myocardium, we go just a little bit beyond that would be my advice. Okay, now this is what I've just mentioned was in the absence of a phase sensitive or PSIR reconstruction. So in the top row, you have standard delayed enhancement images or magnitude images. And in the bottom, you have what we term phase sensitive. This sort of acquisition corrects for mistakes in nulling. I don't want to get into the physics of it too much. Basically, you're getting another image that allows you to assess polarity, so to speak, whether or not you're above or below zero crossing. So at this point, it recognizes that you're too early. So this is actually, this apparent high signal results from you being below, not above, below the zero crossing line. And it fixes that. Okay. It can fix, phase sensitive can fix some things, but it's imperfect. And I advise you to still try and get the correct inversion time. These are all off by a little bit, you know, but the phase sensitive corrects for a lot of errors. Having said that, it's still better to get the correct time if you can. So the point of viability imaging is that you're looking at areas of scarring that appear to take up gadolinium, but it's not really like a homing agent for scar, right? It's apparently taken up because it's normal myocytes exclude gadolinium, right? And so there's a really good series of experimental images that demonstrate a near fingerprint match between the areas of enhancement on MR and the areas of infarction. Okay, so here's what ischemic injury looks like. Notice the thinning and poor wall thickening in the anteroseptum here that corresponds with an area of extensive infarction, blah, blah, blah. So we can do those. There are two types of inversion recovery sequence, the segmented high resolution version, we call it, or the single shot version, right? And we acquired the gradient echo images with high resolution, 256 by 200 or 256 by 256, and they're quite elegant. A little bit more sensitive for infarct detection, right? The steady state free precession images we require is a stack of images. Their resolution is slightly less. We use a 192 matrix. I would not go below that because you don't need to. A, B, you want to have as good a resolution as you can. Notice that not everything that enhances is scar. Some things, including sarcoid and fibrades, etc., or it may be scar, but it's not always myocardial infarction, right? Like in this case, it's an LAD, territory lesion, RCA here. Notice that you're following a coronary territory, right? I think another important point with MR is that viability, although for any individual cell, it's either alive or dead. Viability is binary, yes, no, live, dead. But for tissue thickness, it is a continuum function, right? So like here, this is 1 to 25%. Here, it's 25 to 50. Here, it's 50 to 75. Here, it's transmural, greater than 75. Why does that matter? Well, there's a lot of experimental data that indicates that the likelihood of improved contractility following revascularization is directly related to how much infarct you have. And below, once you have greater than 50% transmural infarction, the likelihood of recovery just drops way off. If you don't have any infarction, or if you have varying degrees of infarction, you have a pretty much continuous relationship between the likelihood of recovery of function. And it's not exactly like half is not going to recover and half will recover. What's going to happen is you'll probably get a moderate recovery of function as opposed to a really near total complete recovery, right? How about compared to SPECT images? In a study of 91 patients, SPECT missed about half of the subendocardial infarctions. Here's that dog model I showed before. Here's SPECT images, histologic images, clearly an infarct on MR, no infarct evident on SPECT images, right? Because SPECT images can only show you what's alive. The only way you're knowing what's dead with SPECT is if the photon deficit is sufficient, right? Whereas with MR, you're directly demonstrating not only what's alive, you're showing what's dead, and it makes a huge difference. The other thing is that our spatial resolution is 40 times better than SPECT imaging, so it's not a shock that it's easier to see infarcts. The other point I would make is that knowing what's viable is not really all the story, right? Like in these cases, you have two patients. If you lay out their myocardium, their viable myocardium, in a band-like fashion, you see there's some regional variability. Right? Same thing with this guy, regional variability. in wall thickness. But that variability in thickness would, if you were comparing them, you would not be able to depict the infarct that's clearly apparent in this guy because it doesn't result in a significant deficit in wall thickness, right? So you would miss that infarction if you're just, even if you could see in perfect resolution only what's viable, you won't see the area of infarction because you're only seeing what's viable, right? So I'm going to close this because we're getting to the end of the hour. Basically, here's two patients. I've shown this in other talks, but basically you have pre-op patients. Both of these guys were known to have had known to have prior MIs, and they had cine images and they were asked to assess viability. Well, if you look at that, they have dysfunctional myocardium. It's a little bit thin. This guy's quite significantly thin. Both of them have impaired function. On SPECT images, they're both read as having, significantly impaired uptake with dyskinetic motion, probably scar. But if you do delayed enhancement, this guy has extensive transmural, probably greater than 50% transmural infarction. This guy just has a little teeny bit, in some areas he doesn't even have any infarction. So who's going to get better if you revascularize him? Right? We've said that if you have 50% or more, you're not going to recover. This guy has way less than 50%. So indeed, this is like science fiction. You think, oh, this can't be right. But it's true. These are real cases. They really can recover profoundly. And Deepan Shah and Ray Kim did this study where they looked at people who had wall thinning and looked at them from baseline to follow up. If they had less than 50% scarring, they recovered profoundly. If they had more than 50% scarring, not so much. Okay, here's a case I had from one of my fellows, nice anterior wall deficit. She'd had a prior PCI, kept having chest pain, thought to have on nuclear studies scarring, but the clinician didn't believe it. So they did an MR and it looked like this. So what will happen if you revascularize this? Nothing, there's nothing viable. Yeah, she may improve if they resect the anterior wall or she can recover. Well, the answer is do you think this is enhancing at all? And certainly it's not greater than 50% enhancing. So you revascularize her, she looks like this. And this is not, this is not rare. This happens in not infrequent proportion, but you'll never know. With viability, you need to know not only what's alive, you need to know what's infarcted, and you need to know the ratio of scar to viable myocardium. And the only thing that can do that is CMR. And we can also use these to depict thrombi and characterize masses. I'm sorry, we're going to have to close this out. Maybe we can talk about some of these other things. I'll just mention that thrombus, when we say we do long inversion time imaging for thrombus, it's so thrombus reaches the null point way later, right? So maybe 500, 600 milliseconds. That's why we use those long TI sequences. We use these for cardiomyopathies, amyloid. So which sequences we use depend on the clinical concern. Probably we ought to always do cine imaging covering the entire LV. Like gadolinium is probably useful in almost all cases. And I would point out MR is not just one thing, as opposed to CT, which is always one thing. You're shooting x-rays through and collecting data on the other side in a detector. And that's the same thing you do every time you do a CT. But with MR, you have one piece of hardware, but you can use multiple different software parameters to get viability information. You can do flow studies. You can do perfusion to look for ischemia. You can do functional analyses. You can do MR angiography. And it's, to me, the best way to look for cardiac masses. So it has a lot of capabilities, and hopefully we've touched on some of them today. Okay, so that's what I had. Anybody have any questions? Feel free to chime in or chirp up or whatever.
And Shannon, do you mind putting up the theme?
Oh, here, no, I've got it. I forgot, but there it is.
Thanks, Dr. Grizzard, for that overview. And I just, had a question, which is that you sort of showed us all the unique capabilities of MRI and how precise we can get with some of our imaging sequences. But there's a number of people in the field sort of pushing for these rapid sequences to try to increase our throughput and make MRI more available to patients. Do you have a general sense, if you use just the lowest resolution techniques, but the fastest ones available, like real-time CNAs, single shot images, what proportion of patients do you think you probably wouldn't be able to give a very specific answer on, or we might miss the diagnosis?
That's a great point, because there is a lot of movement in that direction, and I think as the image quality improves, it'll become, less of a disparity between the what we call high resolution standard imaging and the accelerated imaging. Like you've seen the compressed sensing, and some of those cine images are, pretty good, probably good enough. And the single shot delayed enhancements, people have studied that, and if you get multiple imaging planes, it's probably 90%. It's probably not 95%, but it's probably 90% that's good at picking up stuff. Yeah, I think that's going to be a progressive trend. Actually, I think people worry a little bit about AI and what will its impact be. We're at the cusp of a real revolution, I think, as far as that goes. Hey, and I think the answer is that I think AI will help on both parameters. I think it'll allow a further acceleration of imaging. I think that it'll help with the detection of abnormalities, and I think there'll be improvements in reconstruction algorithms that'll enable that to go even faster than you can imagine. Like there are people doing 3D acquisitions, just the machine's on autopilot. The techs are basically hitting a button to start and then a button at the end. And all the other stuff, all the functional data, all this contrast information, everything is acquired without operator intervention in some of the, futuristic sci-fi kind of settings. I think something like that will probably happen. I think it'll still, and you could argue that it can even read, at some point you probably just normal study click, or anterior wall infarct, residual. But I think there'll still be a need for human interaction to steer it when it goes off the rails and to interpret it. So I don't really worry about it. I do think I think there is going to be that trend. I think I personally resent it because I find it most helpful to have the best resolution, and it bothers me to think that I might be missing something, right? But the people who don't get a scan, you miss entirely their pathology. So I get the idea of increasing access, right? So I think it'll be a balance, but it has to be good enough. That's the thing. I don't think to this point it's been quite good enough, but I think it's rapidly approaching that.
Thanks.
Anybody else? Oh yeah, hey.
Everywhere I've been, we do 8 to 10 minutes, like gadolinium enhancement, post contrast.
Okay. Yeah.
But we do 5 minutes here.
Well, I think it depends on how much contrast you're giving, right? So if you give a full, I'm sorry,
we're still giving double dose for.
I think we're giving 0.15, aren't we? Well, the answer is that 5 minutes is too early, and I don't know why we're doing that if we are. Okay, we should be doing 8 to 10 or 10 to 15 if you're giving a double dose. If you're giving a single dose, you can go earlier. And if you're going, in a lot of places, they're moving, particularly at 3T, to giving 0.15 millimoles per kilogram, as opposed, which is like 0.3 cc's per kilo. And they're moving that way, and then you can scan earlier. The other point is I think it's important to note whether you're talking about a stress test, because you're giving 2 doses for a stress test, you can do your second acquisition much less than 10 minutes after that second dose. So I'd be really careful that you're not talking about in general, or you're talking about specifically stress testing. If you're doing stress testing, because you've given a prior, half the dose, 5 minutes ago, it's not a problem. When you get that second dose, you can scan almost within minutes. I mean, within a couple of minutes after that second dose. That would be the exception, sort of, in general, anyway. And those are used. We are using 0.2 millimole total in those cases, I think, a lot. Right? When you're doing stress testing, we're giving 0.2 total. 0.1 and then 0.1. Yeah.
Well, thanks again. Thanks for everybody
Sure.
participating. We'll see you back next week.